Hello everyone, welcome back to this interview series here on the YouTube channel. Today I am delighted to be joined by Mr. David Mathews, who is an HCPC registered biomedical scientist currently working in haematology and blood transfusion in a hospital within the NHS in Northern Ireland. Thank you, David, for joining us this evening.
No, thank you very much for having me.
Awesome. So tonight we will be discussing, since it's the first time we have a fully trained, fully registered biomedical scientist on the channel to chat to, we'll talk careers as a biomedical scientist, I guess how maybe a biomedical science degree plays into that, the career options available, and the role of the biomedical scientist within the NHS and the care that patients ultimately receive. So, could you just give us a quick summary, David, kind of who you are, how you got to where you are, and what's your day to day, if that's all right?
Yeah, absolutely. So, yeah, as said, I'm David Mathews. I'm a biomedical scientist. I initially got here through studying an accredited biomedical science degree at the University of Ulster. Within that was a placement year in which I did haematology and blood transfusion, and ultimately that really interested me, and so I have gone back to the NHS now as a registered biomedical scientist.
Amazing. So, even from what we've said so far, I've already got a ton of questions.
Okay.
um, so, in the introduction, and the way you introduce yourself to me for the purposes of coming on was you are an HCPC registered biomedical scientist.
Yes, that's correct.
What is the HCPC?
Okay, so the HCPC is the Healthcare Professions Council, and it regulates 17 total professions at the minute, and they're basically the allied health professions, so paramedics, art therapists, psychologists, any allied health profession that doesn't really have its own regulatory body. So, for example, obviously, nurses are registered with the NMC,
Hmm.
doctors with the General Medical Council. The HCPC just regulates the allied health professions essentially.
Cool. So, how do you, I suppose, become registered, I suppose, is the question that follows from that.
Yeah, of course. So, in terms of for biomedical scientists, it starts with your degree choice. So there are many biomedical science degrees out there, but the important thing is if you're uh, choosing to practice within the NHS, your degree needs to be accredited, and that essentially means that the modules that you undertake are dictated by a separate body, not the HCPC, the IBMS, the Institute of Biomedical Sciences, which is just the professional body as opposed to the regulatory body,
Sure.
and they outline what modules and what criteria you need to meet in order to become registered as a biomedical scientist at the end of your degree. So within your degree, one of the IBMS stipulations is that you conduct a certain amount of clinical placement, usually done between years 2 and 3. So a 4-year degree in total, a placement year usually between the second year and the final year, in which you'll do all your clinical placements and then obtain what we call a certificate of competence, basically to say that you've met a satisfactory level of practice during that, and then you will graduate eligible to register with the Healthcare Professions Council as a biomedical scientist.
I see, but you're not automatically, I guess similar to the way a junior doctor, you're not automatically granted that registration by virtue of having finished your course.
Well, you sort of are in that you've completed the clinical component, and
Hmm.
once you leave, you can then register with the HCPC for that. So you will become a registered biomedical scientist as long as you apply to do it then.
Oh, I see. So there's no further component, as it were, than the training course.
As long as you have the training that you've conducted on your degree, you're eligible to register. Yeah.
Okay, cool. Okay, that is a difference then. So for the
Yes. Yeah.
people at home, just to place this in context, using the example of doctors, um, as David says, regulated by the GMC. Um, when you finish medical school, you are then sort of pre-registration as a doctor. You do not have a full license to practice medicine independently. That takes a year, your F1, your foundation 1 year as a doctor, and until you complete that year and are deemed safe and knowledgeable and satisfactory, you cannot practice medicine independently in the UK. So that's a good difference to know about there with the biomedical scientists. I guess you're going almost straight into a profession ready to work.
Yes, yeah. Provided you get that clinical component signed off. There are degrees out there where the placement year isn't offered, and although when you complete you'll have to enter the NHS under a trainee post.
I see.
So that would be sort of the equivalent of pre-registration. You'll be working up towards your registration then.
Okay, amazing. And I guess perhaps the question that I should have started with, but got ahead of myself and didn't. I was excited by the acronyms. What actually is a biomedical scientist?
So biomedical scientists, in terms of here in the UK, the term biomedical scientist is a protected title. So although there are biomedical science degrees, and many people have biomedical science degrees, they, unless registered, can't call themselves biomedical scientists. So that term is reserved for those of us who are HCPC registered and therefore working within the NHS. The figure that's thrown around in most biomedical science literature is that about 80% of medical diagnoses and decisions are made on the basis of some sort of laboratory test, whatever that may be.
Sure.
And so the primary role of a biomedical scientist is to be the scientist in the laboratory, carrying out the necessary tests and ensuring that those tests are done accurately and properly. Because I think what's maybe taken for granted essentially at some levels of the ward is that when you receive a result, whatever it may be, that's actually accurate for the patient. What you don't have to do is worry that may not necessarily be true for that patient, because all that work is done by us down in the lab. So we're there to ensure that the results that go out to the clinicians, to the nurses, to everybody acting on behalf of the patient are true results, and then you guys can obviously help the patient then.
Yeah, that's honestly, putting it that way, I think. So everyone who's listening out there, if you're early on, maybe in your preclinical years of medicine, or thinking about applying for medical school, or going to work as a biomedical scientist, I think David's right in that at many, many levels, I'm thinking about the number of tests and things that we request and we order, for every patient as part of a routine set of samples that we request. They need various different blood tests, for example, which, when we say, oh, I just want a routine set of bloods, which might be a full blood count, urine and electrolytes, or urea and electrolytes even, troponins, all these various things that we need. They are independent tests which, as you say, have to be carried out with some degree of oversight, and we rely on them to be very, very accurate. And I think we lose sight all the time that there's actually someone, going and mediating all these tests, and they have to be designed and tested and trialed and things. So I suppose that then begs the question, are there multiple types of biomedical scientist? Because the number of tests that we rely on is incredibly, incredibly broad.
Absolutely, yeah.
So
yeah. Biomedical sciences, in the same vein as medicine, has multiple disciplines, and biomedical scientists will specialize in their particular discipline. Now, how it's broken up in some places is down to each particular trust. But in general, you would be looking at hematology as a discipline, blood transfusion as a discipline, you have histopathology as a discipline, cytopathology, biochemistry, microbiology, you have andrology, immunology.
I think I'm going to
There
have to
are
ask you to break down, like, that there's a lot of jargon flying around. So
yes,
some of
yes,
these terms for plebs like me who actually don't have to think about what these words mean, we just say them.
yes.
What actually is something like hematology or biochemistry? What do you actually mean?
Yes, so hematology is obviously the easiest one for me to talk about because I am a hematologist. So in hematology, we are primarily concerned with the blood itself, the cells, and the parameters associated with those cells. So the likes of how many white blood cells are floating around in your blood, what particular types of white cells those are, things
Mm.
like that. We're also concerned about how your blood actually is doing in terms of how it clots, how you're able to effectively stop blood loss. In the blood transfusion lab, we're primarily concerned with ensuring that blood that needs to be transfused to people is compatible with them. Obviously, transfusion reactions are very, very dangerous, and so there needs to be that level of oversight from ourselves to say that somebody has checked and seen that this is correct. Um, Things like biochemistry, looking at mostly the serum or plasma component of the blood, things that are in the blood that you'd be looking for. Microbiology, looking primarily at sort of pathogens, bacteria and viruses that cause infection. Um, there's plenty more, many disciplines, but each of them has their own role to play. And you guys on the ward, of course, will be directing your tests based around what it is you're looking for, and it'll go to the relevant department and they'll carry out the test.
Yeah, again, and it's reflecting, suddenly being forced to reflect on the number of almost throwaway comments, that not comments but requests and thoughts that get made on the ward, during that clinical decision making process. Even, someone's got a particularly bad chest infection, we would want to know, perhaps in severe cases, what the particular bug that the person has infecting their lungs. We need to know what antibiotics we can maybe give that will reliably get rid of that bug. Or if we're trying to track particular strains, COVID-19 has introduced a whole
Yep,
load of
yep, yep.
problems with things like this. And we're on the wards, on the external side of all this, very reliant on, as I say, on the accuracy of these tests to help direct what actually happens for the patient. So I think it'd be remiss, given that we have an expert in the hot seat, as it were, to delve into hematology a little bit more, and blood transfusions specifically, because they're,
Mhm.
I would I was going to say, relatively rare. They're something that most people probably won't receive, maybe
Mhm.
as part of their standard package of care. Um,
Yes.
so just let's cover the basics of that. So what is a blood transfusion? Why might someone need one clinically?
Yeah, so in terms of blood transfusion, what we're essentially looking to do is give somebody, uh, in most cases, a unit of red cells, and that's primarily because of anemic patients, so patients whose hemoglobin is under what is normal. Now, there is a normal reference range for hemoglobin. Below that, we don't necessarily want to transfuse a patient. There are specific transfusion limits as well, because, as we've said, or as we do say in the NHS, the safest transfusion is the one that doesn't happen. So we have these specific transfusion limits, but it's not just red cells within the transfusion lab. That would be the primary function, but we're also giving patients plasma,
Mm.
fresh frozen plasma. We're giving them a separate component, cryoprecipitate. Um, we also deal in terms of antenatal clinics. The blood transfusion lab deals with the anti-D immunoglobulin that's given out. Um, there's a lot that goes into it in terms of transfusion.
Sure. And then you mentioned before, and I'd be keen just to hear a bit more. I think people will find it interesting about transfusion reactions and
Yes.
why the process of transfusion, obviously something that you're doing with good intention to potentially save a life. Someone's, let's say someone's had a traumatic childbirth, or they're in for major surgery and the surgeon nicks the artery and they start,
Mhm.
we're losing gallons of blood.
Mhm.
What can go wrong during the transfusion process?
So the major thing for us is that most people are aware of two blood groups. So that'll be your ABO group and your RH group, and that
Mm-hmm.
most people are aware of that. They've given blood at some stage, or know of other people who know their blood groups. So the likes of O positive, A positive, two of the most common blood groups here in the UK. There's actually a lot more to that. There's closer to 200 blood grouping systems. Um, and not all of them clinically significant, but some of them are. And the general idea is the same as with the likes of the ABO system. If you get a blood group that your body doesn't naturally produce, you can develop an antibody against that blood group, and that can cause you to attack the cells that are transfused to you. So, in terms of what we can give to people, it's based on their compatibility with many of these different blood groups. Now, for most people, that's not going to be a major issue. For someone who is, say, for example, a 25-year-old male who's never had a transfusion before and is, for all intents and purposes, fit and well,
Mm-hmm.
it's likely that their ABO and their RH group are going to be the only two that we need to really worry about. In terms of other patients, however, so some of the hematology patients with a lot of blood cancers who require continued transfusion support, over the period of time that they require that support, they will develop these antibodies to the various groups in the red cells. And so then we start having to narrow down more and more as to what we can actually give them to continue that transfusion support.
Okay, so it's a lot more complicated than clinically, as you say on the ward. Whenever it
Mm-hmm.
comes up, I guess all I ever think about is their ABO group and rhesus, positive or
Yes.
negative.
Mm-hmm.
But behind the scenes, it's as with most things, it sounds a lot more complicated than that potentially.
Yeah, yeah, exactly. And it's not always uh, like an episode of House. It's not always clinically significant. It can sometimes just be some really silly things like cold antibodies that react at room temperature but won't react at body temperature. So although they're not going to cause an issue, if we are checking compatibility, in a slide, for example, it'll look like the red cells have stuck together, and that'll look incompatible to us. So we have to make sure that is just a temperature related antibody. It's not necessarily always about disease purely. There are pre-analytical factors and analytical factors that go into
That's really, really interesting. And clearly, I've got a lot of reading to do. Because all this stuff we take for granted. However, I think while we have you here, it's really important that we talk about the more careersy side of things,
of
because
course.
this is one of the great, not controversies, but it's a sticking point for many people, and it's certainly something I've made jokes about myself, that
Mhm.
a lot of people who take biomedical science courses, there is this not stigma, but there is kind of a long running joke that
Mhm.
a substantial portion of people that take these courses wanted to go to medical school to become medical doctors, but for whatever reason weren't able to do that. And
Mhm.
that is the singular focus of this body of people to complete their biomedical degree and go on and study medicine as a graduate
Yeah.
entrant.
Mhm.
What's your feeling on that?
I can definitely see where it comes from. I don't necessarily think it's entirely true. As with any cliche, there's some truth to it, but it's not necessarily the case. I know in the class that I did my degree with, I know of one person who had wanted to go on and do medicine, but that was in a class of maybe about 150 of us.
Wow.
Um, and that was all. But one thing I will say is it's easier to see on accredited degrees. So, like I talked about earlier, the ones that are laid out specifically with the path of going into the NHS. The people on those accredited degrees tend to be there because they want to go into the NHS as a biomedical scientist. For the people who are on the non-accredited degrees, some of them are there because they didn't even know there was an accredited degree. I know
Yeah.
whenever I was applying to biomedical sciences, I was quite hung up on the jargon, and I didn't know whether I needed to do accredited or not. Or, but those people can sometimes be there because they want to do medicine eventually. But there is certainly a lot of us who solely want to work in the NHS as biomedical scientists. It is a profession. We are there, and it's unheard of for a lot of people. They don't know that we are there, and it's good to get awareness out there. But yes, I think it's important to realize there are people that are there to be biomedical scientists.
Yeah, it's the only reason I bring it up, as I say it's. I don't know whether this is an English thing because you say you studied in Ireland, or whether it's a distribution thing. I think, for better or worse, biomedical sciences is often seen as because you can only pick 4 of your 5 application slots can be for medicine or for dentistry or for veterinary, I think is included as well.
Mm-hmm.
It's often seen as the reasonable 5th choice. That may have changed in recent years, and I hope it does, to be honest, because, as you say, it's a very esteemed profession of its own, independently accredited, and an incredibly significant part of the process. Almost the people who we actually need to understand what's going on, almost at that very advanced level. So people can go to university, they can do their biomedical sciences degree. What, I suppose, career options might be available to someone? Maybe you don't want to go and be a lab scientist, working at the bench all day. Are you confined to that role? Are there other things you can do?
Absolutely not. There's no confinement. The way I always put it to people is that if you go and do the NHS accredited biomedical science degree, you can work in the NHS and you can do your NHS biomedical sciences, and you can work anywhere else that the average science degree will let you work. So you have the option of going down this accredited route into this profession, or you can go elsewhere. I know of people that have gone off to work for agricultural authorities, lived on boats for 6 to 8 months and done water sampling, still science based, but out in the middle of the English Channel, doing something completely different. I know of people that have gone into science communication, people that have gone on to do PhDs, people that have gone off to different continents to do field work in animal studies. You can do anything with a biomed degree that you can do with any other science degree,
So it's really, well, both good and very interesting to hear. What I would be interested to do, again, purely just thinking of the audience that I hope, fingers crossed, is watching this at home, is I think it's important that we differentiate, as I'm keen to do whenever I get the chance to talk to other health professionals. Why should someone consider a career as a biomedical scientist over a career in medicine, for example? What advantages can that profession offer?
So primarily, if your idea of healthcare is getting a really good in-depth knowledge and understanding of not just human healthcare, but how we actually arrive at forming a plan for helping people. So, as we've said multiple times in this interview already, there are a whole team of people that have to sort out, in this case, samples before these results make it to yourselves on the wards, to the nurses, to the physios, whoever is taking these results. But what we get is the picture from start to finish. So we'll have a sample come in, and hopefully somebody will have provided us with good clinical details on the form. And of course, we have access to care records and whatever we need to carry out our work. And we're seeing why the sample's in. We're able to carry out the test and make sure an appropriate result is given out. And then we're also able to monitor the journey. It's maybe not obvious to a lot of other clinicians, but we get to know a lot of the patients on the wards and who's being cared for, because we will get repeat bloods multiple times throughout a day, and you get to know who's being monitored more closely and who's not. So it's honestly not as if we just carry out this test, send off a bunch of numbers on a sheet, and then head home at 5 o'clock and are none the wiser as to the patient's journey. That's not true at all. I guess what I'm getting at in this roundabout manner is that the journey that happens before a diagnosis is made is where biomedical science really shines. It gives you the opportunity to mix in that scientific knowledge with the clinical knowledge.
Definitely. I think again, I find myself saying in almost every interview that I do, I think that the public facing view of what medics do is a little bit flawed, in the sense that I think people feel that doctors occupy a much larger percentage share of the process than they actually do. Doctors and nurses and healthcare assistants, that those roles are about service delivery, right? It's people on shop floor, whereas as David has said, for the NHS to function and for people to receive healthcare, it relies on this incredibly complex network of processes. But in order to get that, clinical staff, patient-facing staff, are very much more generalists than I think people think they are. And particularly when I'm talking to people during mock interviews and things and say, why do you want to be a doctor? And they say, well, I'm really into my science and I enjoy talking to people, which are part of the reasons why I want to train to be a doctor. Because you are doing a mix of things, you almost by definition have to become a jack of all trades, master of none. And this is, I think, something that's really important to appreciate, that it is almost virtually impossible for a medical doctor or a medical staff member to know as much about these processes as the biomedical scientist will do, because that's not your job. I guess the medical side of things is the patient interaction, the logistics and decision-making pathway, but in terms of understanding what's going on and, say, making sure these tests are accurate and designing the next set of therapies and drugs and tests that influence what happens, that's not really the role of a doctor, even though many people might presumptuously think it was. But I think, if you're okay, David, I did have some questions sent in that...
Okay, yeah, go for it.
Okay, so the first is, as a perhaps incompetent medical student myself, David, why do you keep rejecting my blood samples when I send them to your lab?
If it's a blue top, it's because the ratios are wrong. So for something like a blue top sample, that bottle is designed specifically that there is a ratio of the anticoagulant in the sample to the blood.
So just
Uh,
very quickly, again, we might have to keep it super basic. What's a blue top? Why might I send that to you?
yeah, so a blue top is it has a light blue top on it. It's a little blood bottle that you guys will collect the blood in, and you'll send it down to us specifically for coagulation studies, which is how the blood clots. Um, the reason those are so pernickety is because there's a liquid anticoagulant in that, the portion of it that stops the blood clotting before we make it clot. And if that ratio is wrong, then I, as a biomedical scientist, can't stand by the result because it may be overclotted or it may be underclotted by the time I put it onto my analyzer, basically. Um, Other common reasons are simply really simple mistakes on any top. Now, I'm talking about now, not just a light blue top, but spelling mistakes, incorrect patient details on the sample. I can't give you a result for that if I can't guarantee it's the patient. Um, and simply not enough in the tube.
Yeah. So just to illustrate again, for those at home on our end, say if we want to know, as David said, this example, how someone's blood is clotting, we have to bleed the patient. We will, put a cannula or a needle into their arm, put some blood in a color-coded tube, the color associated with a particular type of test or a type of sample that needs to go in that tube. We'll then label it up, which is what David's talking about. They either come with a label on the tube, or we will put them in a bag with a label on it. So we might write the patient's name, their ID number for that hospital, maybe the ward where it's come from, the time the sample was taken, these kind of useful bits of information. They then get sent either on foot or through a network of pipes if you have a pod system, send stuff flying all around the roofs of the hospital. And that then, I guess, lands in a bag in your lab, and you will do your processes, put it through your machines. But as David said, these types of errors are very, very common. And unfortunately, if I take someone's blood, and I've done this before, say I mislabel a troponin or something and I don't label the bottle properly, as you say, that the patient will never get the result for that patient, and then that means the patient has to sit there a few more hours and has to be bled again because we probably need the results of that test. What are the challenges that you find in your career? Either that can be constrained to working in the NHS or the actual role of a biomedical scientist.
That is a good question. I think every day has its unique challenges. Obviously, scientifically and clinically, there's a number of challenges that come with the territory of being the scientist behind the test that's being done. Relationship wise with a lot of other allied health professionals, because for the vast majority of other health professionals in the hospital, a biomedical scientist is essentially only found on the end of the phone, with the
Yeah.
exception of a few professionals. But for that reason, it can be difficult sometimes to convey the message that you want to some people. And just generally throughout the day, trying to get turnaround times met is another really big one. I mean, for the likes of emergency department samples, we have an hour's turnaround time, and that's from the time it lands in our lab to get a result out to them. Meanwhile, hundreds, and in terms of hematology, for certain, hundreds of other samples from GPs, from clinics, from every other ward in the hospital are constantly piling in, and we have to prioritize those. So I suppose time management can be a big issue for ourselves, and organization is a good trait to have. But challenges are met with enthusiasm in the labs.
Yeah, I think you've really certainly. I'm not obviously a clinical member of staff, but as someone, as a more senior medical student, you are often tasked with chasing these samples up, and you do end up on the phone, going, listen, like, I don't mean to pester you, but we really need this sample, like this, this person, because as you say, for sensitive things, someone's having a heart attack, certain types of heart attack. The only way you can clinically make that diagnosis is if we have the result of that test, your troponin, and in the meantime, you've got a person sat in the emergency department in an awful lot of chest pain, waiting for the medics to do something about it. But obviously, in that moment, and particularly in ED where everything's busy, we will not appreciate what's going on. People trying to run these tests. I mean, this is purely an interest question, but how long does the typical assay or test that you might, say you want to do me a full blood count?
Yeah, so I mean, this is going to be quite variable, depending on even what analyzer the department is using.
Sure.
But in terms of the time from the sample enters the analyzer until the time it comes out, you're talking only maybe 10 minutes. The majority of our time spent with that sample is ensuring that it is, like I say, correct for that patient. So if everything's fine on that sample, if all the things fall within reference ranges, we can have that sample sent out, probably within 40 minutes, excuse me, after doing all of our checks. But all it takes is one thing to be off, and that's an issue for us. Something as simple as in our trust, for example, if a platelet count is below 100, we have to check it to see if it's clotted. So that's going to add another 5 or 10 minutes by the time you find the sample, get it out. You then have to stain a slide and physically check it down the microscope to see if there's clots in it. And if that is a true result, yourself, with a platelet count that low, then that's obviously something that's going to be looked at and assessed. So we in the labs also appreciate the clinical severity of these things as well, and we do our best to try and get the things out on time. But yes, for the likes of a full blood count, it's really only a 10-minute assay.
Yeah, I've just never really thought about it, so it seemed like a good, because I remember I had that specific conversation working on an acute cardiology unit the last few months, kind of like, we really are supposed to have these samples back within an hour, and it's been an hour and 2 minutes, and having that horrible, presumptuous conversation.
A thing that we get quite often is phone calls from the wards asking where samples have been because they left them maybe 40 minutes ago, but we don't have the sample in the lab yet. There are errors between the ward and us as well. And because they've left the ward, it has to be our fault from that point on. But it's not always the case,
Yeah, and I think it would be shameful to not ask, as someone has asked anyway. I've asked you about perhaps the more challenging parts of your job. What's the best part of your job? Why do you do what you do?
Seeing patients recover. We see patients recover before you guys do. Like like I was saying, if there's a patient that's in getting regular full blood counts, for example, and they're having a hard time, obviously we're on the phone between yourselves and us trying to figure out the best sort of way to approach the patient. And say for example, if they have a low hemoglobin and they're transfused and their hemoglobin creeps back up and all their other parameters are starting to fall into line, we're seeing that happen, and each result is physically checked by us before it's released to you. So we're always more than happy to let a result go in a case of a patient that's been improving over that day, over a number of days. That is certainly the best part for me.
Amazing. Well, that probably makes a rather wholesome and encouraging place to end. Do you have any final kind of comments or pieces of advice for people who might be considering careers in biomedical science?
My only piece of advice is to simply have a look at biomedical sciences as a career option within the NHS. Most people haven't done it. Most people know that biomedical sciences is a degree, but don't know where it can lead. And I think it's a very worthwhile option to at least have a look and see if it's something you would be interested in.
Perfect. Well, David Mathews, HCPC registered biomedical scientist, ladies and gentlemen, thank you so much for joining me this evening.
Thank you very much for having me. It's been a pleasure.
Perfect. Well, take care, David. Are you happy to be contacted by our viewers?
I am. Yeah, absolutely. I'll leave some contact details with yourself.
Perfect. We'll pass those on to you guys. Thank you very much, David. Bye for now.